Now we have our own Dr. Satyamurthy. Today, I think we are going to discuss this newer ways to fixing IOLs in absence of capsular support. Dr. Satyamurthy.
Yes, sir. Thank Yeah. Okay. Right. At the outset, I'd like to thank the organizers for giving me this opportunity. We have seen a lot of cases of subluxated cataracts, dancing cataracts, wherein we could insert CTRs and then some of place the PCAL, but still there are situations where you will have to manage without capsular support. So I would like to just discuss about the previous. I will not show the previous surgeries at all. Now the drawback with these polypropylene sutures are that tennoprolene, the tennopolypropylene suture is very commonly used, but it is prone to develop biodegradation. It's called semi-permanent suture. So after about 5 years, 10 years, we see the people coming back with IOL dislocation. Same thing with 90 polypropylene also. So because the material itself is like that, it can undergo biodegradation. So now this particular material which is used in cardiovascular surgery, this is made of expanded polytetrafluoroethylene, what we commonly call as Teflon, which is a permanent suture and inert. So I would like to show various this is just a before showing the videos, I want you people to see what exactly it is. And then we have customized the needle. See the previous one, the needle it is a curved needle. Even though it is atraumatic, it goes through 21 or 20 gauge needles. So it's not possible to do without stitches. So that's why we customized a regular sewing needle. The top one what you are seeing is about 7.5 centimeters in length, which has got an eye. It's a regular sewing needle, the thinnest I could get. And so now I requested one surgical company, so they helped me to bring it down to 16 millimeters, 1.6 centimeters, with a tapering end, and that goes through 26 gauge needle. So this helps me to perform surgery with the 26 gauge needle itself. This is an aphakia where I am just performing the Hoffman's pocket. So once it is done on either side, the anterior vitrectomy is done, and then now the previous tunnel is open. AC is eye was little soft after vitrectomy, that's why. So now using 26 gauge needle and using this customized needle, which is threaded with the Gore-Tex suture, so now it is brought out with a loop outside. Same thing is repeated on the other side. So now we have two loops on here, and then through the Hoffman pocket the suture was retrieved outside. And now using the regular skill fixation forceps and using this claw hitch knot or girth hitch knot, so the suture is fixed on either side, the loop is fixed on either side of the eyelet. This is repeated on the other side, and now the IOL is inserted just like regular IOL. After completing the knot goes into the Hoffman's pocket, and then eye remains very quiet because this particular material is known to be inert. So this is the end of the surgery. IOL is very well centered. Pupil is not exactly round because there is iodectomy performed during the primary surgery. That's why it looks little elongated. Now this is another surgery where this is a modified M1A technique. instead of using the 26 gauge needle, this is 25 gauge trocar and cannula, which is inserted at 180 degrees apart, and then this is a regular hydrophobic 3-piece foldable lens from Johnson & Johnson. This is inserted completely into the antechamber. Now the cannula, trocar and cannula is removed, and using the ILM forceps and using this handshake technique, ILM forceps goes through this 25 gauge opening, scleral opening. One haptic is externalized. Similarly, the other haptic is also externalized. While external other haptic, surgeon holds this haptic so that it doesn't retrieve inside. And using this Canabrava technique, the haptic, the PMMA haptic is cauterized to create a flange, and that goes into the under the conjunctiva into the scleral. So this way the lens remains centered. So this is a slight modification, and this is another way of doing. I mean, fixing the lens in the absence of capsular support. So here the at 90 degrees the cornea is marked, and then using AC maintainer, now I am sitting at on the temporal side, so about 1.75 millimeters from the surgical limbus, and then 2 millimeters on either side of the central point. So now using the same railroad technique, and the 26 gauge needle is passed at this point, and then it is brought out, and then it goes under the conjunctiva, and then exactly at 4 millimeters it is brought out. Same thing is repeated now. So now you have a suture which is like this, like a rectangle, and now same thing is repeated on the opposite side. So now you have a mesh which is created. We have a mesh created now, and regular PC, like regular 3-piece lens is inserted, like how we do in a regular capsular bag. And now one thing here is, now there are 2 loops, one above, 2 are above and 2 are just below that, and then the optic is captured between the superficial and the little deeper one, so that IOL remains centered. But all said and done, this is again polypropylene 90. So we tried with the customized last video, sir. Customized needle with 60 proline, and the same thing is done. A mesh is created where the central 4 millimeter is open. Now because the globe was collapsing, I had to put air. So same thing is repeated, and now here on one side I cut the suture a little long, and then using the Canabrava technique so made the flange at the center, and then put it under the conjunctiva. Here I have tried a tunnel, and now the whole thing goes under the tunnel, so that the suture, the knot doesn't get exposed. Now we have a mesh here, and then place the rigid 3-piece lens over the mesh, and then capture the optic between the superficial and the deeper portions of the mesh. Lens is very stable. Yeah, now that's another thank you very much, sir. So we are now trying with Gore-Tex suture, the same technique, because it remains permanent. See, in my opinion, scleral fixation is like plastic surgery, oculoplasty. You will have to use your this thing and then imagination, and then you can sew this it. So thank you very much for your patient listening.
Dr. Satyamurthy, it was wonderful, seeing your videos. Very nicely demonstrating all these difficult surgeries per se. I think, Suturing, which we have been using nylon sutures, we have seen patient coming back to us with a total subluxation, sutures getting degraded, and the Gore-Tex suture is going to change the entire scenario. So that is important to have suture going to last for that longer period. Otherwise, nylon sutures within 10 years they lose their strength, and sometimes we have subluxation happening. And this mesh technique is beautiful, where you entangle the lens and by getting a sort of a capture happening in the tube. Very nice. It's like a bridging the lens in the eye. Thank you, Satyamurthy.